welcome to the Zoom meeting. So today the press team is going to present Dr. Rufida. I can go ahead when you are ready to moderate this meeting.
Thank you very much. Hello, everyone. I hope you're having a good day. So today, the red team going to be presenting, and I'm going to be modulating this meeting. So our agenda for today is we're going to start by speaking about hematology in older adults. It's going to be presented by Dr. Duaa and me, myself. And the second agenda is going to be how to develop quality research. And writing a manuscript. It's going to be presented by Dr. Sara. And then we have a presentation about ANOVA, which is going to be presented by Dr. Lena. And then after that, we do have the role of acute care in prescribing opioid epidemics. It's going to be presented by Dr. Hammad. And we're going to sum up by speaking about the project updates. So bear with us. So I'm expecting Dr. Duaa to be our next presenter.
Yes, I'm here.
Yes, okay.
Thank you so much. I'm gonna share my screen. Okay. Everyone can hear me clearly, right? Are you able to see my screen?
Yes, it's clear.
Okay. So today we're going to be hello everyone, my name is Duaa. I'm going to be presenting hematology in older adults with my co-presenter, Dr. Rufida. The objectives for today's presentation is that we be able to describe how hematopoiesis changes with age, the classification and workup of anemia, how to identify and manage thrombocytopenia and thrombocytosis, qualitative platelet problems, clotting disorders, bleeding disorders, myelodysplastic syndromes, and chronic myeloproliferative neoplasms. I'm going to be covering hematopoietic stem cells and aging, along with anemia, and my co-presenter, Dr. Rufida, is going to be covering platelet-related and coagulation disorders with myeloid hematologic malignancies. Starting with speaking about the hematopoietic stem cells and aging. Generally speaking, the hematopoietic system derives from a small pool of hematopoietic stem cells. They can either self-renew or differentiate to form mature RBCs, WBCs, and platelets. This system is tightly regulated by a complex of series of interactions among hematopoietic stem cells, their stromal microenvironment, and regulatory molecules. The orderly development of the hematopoietic system and the maintenance of homeostasis require a strict balance between self-renewal, differentiation, maturation, and cell loss. So studies in mice show that with aging, there are like 3 changes that can happen, which leads to a skewed pattern of myeloid lymphoid differentiation. These changes are reduced ability to regenerate the hematopoietic system, decreased ability to generate mature lymphocytes, and finally increased propensity for myeloid differentiation. So this imbalance here is thought to be an inherent attribute of the aging hematopoietic stem cells. The myeloid dominance of adult human leukemia may be driven by this skewed pattern, which is age-related deficient lymphopoiesis and development of myeloid clones. The most common disorder of hematology disorders in older adults is anemia, and this is what we're going to be talking about next. It's the most common age-related hematologic abnormality, and it's diagnosed by the World Health Organization as hemoglobin concentrations of less than 12 grams per deciliter in women and less than 13 in men. Anemia is generally has a higher prevalence in older adults. Adults of 65 years or old, the prevalence is 10.2% in women and 11% of men. And in older adults, in older geriatrics of more than 80 years, The percentage is 12 to 16% in women and 18 to 22% in men. But still, the exact etiology of anemia remains unexplained despite appropriate evaluation. So if older adults get anemia, what do we expect that it leads to? Generally, it leads to decreases in cardiac output, local tissue hypoxia, aggravation of comorbidities, and most importantly, functional decline. Anemia in older adults is associated with impaired performance-based mobility function. Usually patients present with fatigue and inability to carry on with their normal activities. Women of 65 years older or old with hemoglobin levels of less than 11 have a higher risk of all-cause mortality than those with hemoglobin levels of 12 or more. And this risk is independent of the presence of other comorbidities. In classifying anemia, we have three classifications. Depends on the cause. It's either hypoproliferation or ineffective erythropoiesis. And the third classification is hemolysis. Examples of hypoproliferation is iron deficient erythropoiesis, like iron deficiency anemia or chronic anemia. Erythropoietin lack, like in renal disease and endocrine disease, stem cell dysfunction, and aplastic anemia. Ineffective erythropoiesis can be caused by macrocytic anemia like vitamin B12 deficiency, folate deficiency, or myelodysplastic syndrome. We also have microcytic and normocytic causes. Microcytic like thalassemia and sideroblastic anemia, which also can be macrocytic or normocytic, and normocytic like myelodysplastic syndromes. Causes of hemolytic anemia are either immunologic, like idiopathic and secondary to immune disease, or intrinsic causes like abnormal hemoglobin or metabolic. The third one is extrinsic, like mechanical, for example, mechanical heart valve. So when the hemoglobin level is from 12 to 13, decisions about how aggressively to evaluate depend on the clinical judgment and the clinical picture of the patient in general and their symptoms. The principles of evaluation do not depend on the patient age. When the patient presents to us with anemia, we think about different things, like it's either due to blood loss, destruction, production deficit, or a combination of these. Morphology and red cell indices gives us like a picture of what's the cause of anemia. For example, the mean corpuscular volume gives us a picture if it's macrocytic or microcytic or normocytic. If we see anemia with platelet and WBC counts, they help us in distinguishing the RBC lineage problem from a broader underlying bone marrow process. We don't generally do bone marrow biopsy unless we are done with the morphologic and laboratory workup in general. And then we refer the patient to a hematologist for further workup and bone marrow biopsy. An absolute reticulocyte count helps confirm the presence of appropriate bone marrow response. So if we have a lack of reticulocyte, this should trigger review of a peripheral smear to assess for morphologic features suggesting bone marrow failure. In evaluating anemia, generally speaking, we have hemoglobinopathies like sickle cell anemia and thalassemias. These hemoglobinopathies usually are inherited, but we also have acquired hemoglobinopathies. The inherited ones are either qualitative or quantitative. Qualitative like sickle cell trait or sickle cell disease, and quantitative like thalassemias. The signs of these are abnormal MCV or alterations in the morphology of RBCs on the peripheral smear. How do we diagnose these inherited hemoglobinopathies? By doing hemoglobin electrophoresis. But in the case of sickle cell trait, we usually do genetic testing. The acquired assembly defects are like toxins, such as lead poisoning. Another possibility is lack of iron, vitamin B12, folic acid, or copper. It's also important to differentiate between a deficit of intake or a deficit of absorption. Other causes are like acute illness, medications like chemotherapy or medications that affect the immune system too. Toxins can interrupt RBC assembly, resulting in the clinical and lab picture of anemia of chronic disease. Moving on to iron deficiency anemia, it's diagnosed by the presence of three things. One is decreased serum iron, two, decreased transferrin saturation. The third and most important is normal or decreased serum ferritin concentration. It can be treated either parenteral or in oral preparations. And this we determine it by basically how the patient can tolerate oral iron or they cannot tolerate it, and if the patient have severe symptoms or not. So IV administration is indicated in patients receiving an erythrocyte-stimulating agent during dialysis, or if the use of oral iron preparations is untenable. And the choice of IV agent is based on the patient's allergy history and the length of infusion course desired. If a patient comes to us with anemia, especially an older patient, the first thing we think about is blood loss, either from the GI tract, the genitourinary system, or the female reproductive tract. This is a summary of differentiating the cause of iron deficiency anemia. Generally speaking, we depend on serum ferritin if it's normal or we have reduced levels. So if we have a serum ferritin of less than 30 with a transferrin saturation of less than 20%, we think about iron deficiency anemia. And here we evaluate the sources of blood loss, as we said, either from the GI tract, GU tract, or the female reproductive system. If the cause is iron deficiency, we simply give iron therapy and then we check the response. If there is a response, then it's definitely iron deficiency. If it's not, then we have a differential diagnosis of anemia of chronic inflammation, undifferentiated anemia of the elderly, or myelodysplastic syndrome. If the serum ferritin is normal from 30 to 100, but we have a transferrin saturation of less than 20%, we also here think about iron deficiency anemia, and we go through the same circle. If we have a high ferritin, serum ferritin, then we think about anemia of chronic disease or macrocytic anemia like B12 deficiency or folate deficiency. And here we check the eGFR, and if it's low, less than 60, then it's chronic kidney disease, and we consider giving the patient erythropoiesis stimulating agent. If the eGFR is more than 60, we evaluate for B12 deficiency or folate deficiency. If they're normal, then we think about myelodysplastic syndrome, undifferentiated anemia of the elderly, or anemia of chronic inflammation. In treating iron deficiency, the oral route is always the preferred for the first-line therapy. There is no significant difference among preparations with regard to efficacy or adverse event profile. Common adverse events from iron oral preparations are mild nausea and constipation. That's why giving smaller dosages of 15 to 20 milligrams of iron, such as ferrigluconate, may be better tolerated than higher dose preparations. We also have iron drops like iron elixir, and liquid iron drops may be better absorbed than tablets. Usually iron preparation, we need to give it for 6 months or more to see a better response. Moving on to anemia of inflammation or anemia of chronic disease. It's defined by a constellation of morphologic, laboratory, and clinical features reflecting the presence of a major disease process. In these cases, iron abnormalities are a hallmark. We see normal to increased ferritin plus decreased serum iron plus decreased transferrin levels and iron saturation. Bone marrow shows normal erythroid precursors with increased storage of iron. And in this case, we consider measuring the ESR and C-reactive protein to tell us if there is any inflammation. If the hemoglobin level is less than 10, we consider a multifactorial causation like blood loss, malnutrition, or hemolysis. And in this circumstance, lab tests are often equivocal and a bone marrow exam may be required. And of course, as we said before, the clinical judgment, we use the clinical judgment in deciding how aggressive the evaluation ought to be. Treatment is directed toward the underlying disease. There is evidence that patients with profound fatigue may benefit transiently from iron infusions. So if the patient comes to us and we suspect that he has anemia of chronic disease or anemia of inflammation, they may benefit transiently from iron infusions. Some patients also respond to erythropoietin replacement therapy. In the case of bone marrow failure, the common causes are medications like chemotherapy and medications that affect the immune system, like azathioprine, for example, infections, marrow replacement by malignant cells or fibrous tissue. Also, multiple myeloma is a cause, which is a plasma cell dyscrasia, is included in the differential diagnosis and is commonly found in older patients. Another cause of bone marrow failure is pure red cell aplasia, which is isolated suppression of erythropoiesis. In this case, we have reduced red blood cells, but we have normal WBCs and platelets. The causes of this can be medications, lymphocyte abnormalities, or viral infections. Macrocytic anemia can be subdivided to either macrocytic anemia with a normal red cell distribution width, like aplastic anemia, myelodysplasia, and others, or macrocytic anemia with a high red cell distribution width, which can be caused by autoimmune hemolysis, cold agglutinins, or folate or B12 deficiency. Microcytic anemias are the most common, and the causes of microcytic anemias like iron deficiency anemia, anemia of chronic disease, and thalassemia minor. Also, sideroblastic anemia can also present with microcytosis. As we said earlier, can also present with macro or normocytosis. Moving on to hemolytic anemia, we have hereditary disorders like membrane or enzyme defects, like hereditary spherocytosis, G6PD deficiency, and hemoglobin synthesis abnormalities. Acquired hemolytic anemia can be related to the immune system or non-immune related. Related to the immune system, the causes can be red cell infections like malaria and others, or alloantibodies, transfusions, and others, or autoantibodies like collagen vascular disease and others. Non-immune related causes like mechanical damage from heart valves, sometimes ECMO machines, burns, or membrane abnormalities. Also, membrane abnormalities like paroxysmal nocturnal hemoglobinuria. Autoimmune hemolysis is the most common cause of hemolytic anemia in older adults. Differential diagnosis of anemia, we said that the first thing we think about in older adults is blood loss, and generally from the GI or the genitourinary tract. Typical findings in this case is anemia in the case of anemia from blood loss is low iron, low serum ferritin, high total iron binding capacity, reflecting absent iron stores. Also, we have blood loss from medication-related gastritis like NSAIDs, from angiodysplasia, from benign tumors, and also malignancies. Frail patients with contraindications to an invasive procedures like colonoscopy might benefit from advanced imaging. Here, I'm gonna give the mic to my co-presenter, Rufida. Do you need me to stop sharing my screen?
Yes, that would be better. Thank you very much for the presentation. Can you hear me well?
Yes.
Okay, so I'll be taking it from here. Okay, can you see my screen?
No.
Okay.
Yes, now we can.
Okay. Okay, so let me share it. Okay, is it clear now?
Yes, it's clear.
Okay. Okay. So I'll be talking about the platelet and the coagulation disorders. Can you see the screen, right?
Yes,
we can see it. Yeah,
Okay.
you can put the small screen aside. Like if you pull it aside with your finger, yeah.
Okay.
Yeah,
Okay.
you can pull. Yeah.
Okay, let me do that.
It will still appear, but like with your finger, slide it. Yes, that.
Okay.
There you go. Yes.
Okay.
It's better now.
Okay. Okay. So if we start with the platelet and the coagulation disorders, So bleeding diastasis are usually common in older patients. They're uncommon in older patients, but actually when they happen, they are kind of serious. So mucocutaneous bleeding is usually associated with either quantitative or qualitative platelet-related abnormalities. And usually bleeding into tissues when it happens, it's more typical of a coagulation disorders. If we look at the thrombocytopenias, it's usually common and usually multifactorial in older patients. When a platelet count is low, it's usually considered, as I said, life-threatening or a serious condition. And also microangiopathic hemolytic anemia should be also considered, which could be caused by DIC, which is disseminated intravascular coagulation, TTB or thrombocytopenic purpura, hemolytic uremic syndrome or HUS, or heparin-induced thrombocytopenia or HIT. If usually platelet clumping is seen in a sample, in an editor, this could be usually an artifact. So if heparin is added or citrate to the tube, this can determine is it an artifact or it's an actual problem. Also, if we consider the first one that we talked about, which is the IC, it's commonly associated with either severe infections or disseminated cancers. It presents with intravascular hemolysis and consumptive coagulation. At the same time, the suggestive signs that's a DIC, usually the red cell fragmentation or helmet cell, also the presence of thrombocytopenia, homocystinuria, and the prolonged PT and PTT. And also, the management is usually simply we need to treat the underlying cause and provide blood products and support, such as we can give fresh frozen plasma and cryoprecipitate, especially if the fibrinogen is less than 100 nanogram. If we go to the thrombocytopenia, that could be indicative of TTB or an HUS. It's usually characterized by, as we said, microangiopathic hemolytic anemia or hemolysis, along with thrombocytopenia. And it's usually difficult to distinguish from each other. But the thing that tips us that TTB usually associated with neurological symptoms, along with the renal involvement. Also, some people say that it might present with a fever beside the neurological and the renal involvement. While HUS is mainly focused on the kidney, it has more renal involvement. The management is that it's the same for the DIC. It's a supportive care in a form of giving fresh frozen plasma or cryoprecipitate. TTB also sometimes respond to plasma exchange, while HUS is less likely to develop to plasma exchange. And this could be due to the pathophysiological mechanisms, mainly. If we go to the fourth one, which is the HIT or heparin-induced thrombocytopenia, it usually develops after exposure to heparin. The pathophysiology is that there will be an antibodies that bind to a complex of a heparin along with platelet factor 4. And subsequently, those bind to the FC portion of the platelet. And later on, they trigger an escalated platelet activation and then coagulation and hemorrhage at the same time. So the gold diagnostic standard is the serotonin release assay. And this is actually considered a medical emergency because of the severe complications that the patient can suffer. And patient usually, they require discontinuation of the heparin and starting the patient on the direct thrombin inhibitors such as the dabigatran and those. If we go to the idiopathic thrombocytopenic purpura, which is diagnosis of seclusion as a cause of a thrombocytopenia, and it's one of the most common one. Usually, symptomatic patients, like in adults, usually we don't treat, especially in the elderly, we don't treat unless patients are symptomatic. So symptomatic patients are treated with IVIG and steroid, which is get tapered, or a short course of steroid that get tapered later on. If the treatment is unsuccessful, then we can go to the other treatment modalities such as splenectomy, also chemotherapy such as danazol and rituximab. And also we can give thrombopoietin receptor agonists. If we move from the thrombocytopenia to the thrombocytosis, it's most commonly occur as a reactive, but may be triggered by the underlying bone marrow mutations. We have essential thrombocythemia, which is one of the causes of the thrombocytosis. It's a myeloid proliferative neoplasm that's triggered by acquired driver mutation in the JAK2 or JAK kinase mutation, or the CALR or the MBL mutations. The diagnosis is usually established through bone marrow biopsy. Depending on the age and the clinical presentation, patient may need treatment with either cytoreductions, drug therapy, in addition to aspirin to reduce the risk of thrombosis events. And then moving to the qualitative platelet problems, platelet dysfunction disorders, although they are uncommon, but they can cause bleeding in older adults. They either classified as hereditary, such as Bernard-Solier syndrome or Glassman thrombocythemia, or they could be acquired. By far, the most common acquired disorders are secondary to medications such as aspirin and NSAIDs. The platelet function testing can determine the underlying etiology. So if you go to the clotting disorders, the common acquired prothrombotic conditions are usually antiphospholipid syndrome. We have cancers, but a lot of malignancies lead to hypercoagulability, trauma and surgery. And also there are inherited conditions such as prothrombin gene mutations, protein C and protein S deficiency, and factor V Leiden mutations. The antithrombin deficiency is an acquired and inherited clotting disorders, usually caused by defects in inhibiting thrombin and activated factor 10 and 9, which results subsequently in hypercoagulability and usually seen in conditions such as nephrotic syndromes. Most thrombotic events in older adults are provoked and require a limited period of anticoagulation once the underlying cause is managed. The CHEST antithrombotic therapy for VTE disease guidelines and expert panel report is a sound reference for a length of treatment and a choice of the antithrombotic agents. In older patients with unprovoked or unexplained recurrent thromboembolic events, it's reasonable to perform lab testing for an inherited clotting disorders. Up to 10% of the selected octogenarians with recurrent clots have mutations. If we move to the bleeding disorders, in older adults, bleeding disorders are commonly acquired, usually occur with a liver disease or clotting factor deficiencies. Von Willebrand disease is one of the most common bleeding disorders. Although it's a disease of young, but it also could be found in adults, or in older patients. Older adults may also acquire circulating clotting factor inhibitors and even present with hemophilias. Inhibitor to factor 8 is the most common cause. Onset is usually sudden, and patient may present with significant bleeding into soft tissues, including muscles, which is different from the hemocirrhosis events that's seen in congenital hemophilia. Treatment usually involves replacing the factors. Also, the deficiency of vitamin K dependent clotting factors tend to occur in older adults with major illnesses. The common cause is disorders of hepatobiliary tree, antibiotic that neutralize the bowel and reduces the bacterial source of vitamin K, malabsorption syndromes, and severe malnutritions. The deficit are readily treated with oral or intravenous vitamin K replacement. All patients who need warfarin reversal should receive vitamin K replacement. Subcutaneous administration of vitamin K is discouraged because of the slower time to correction of the prolonged INR and variable absorption. In patients receiving warfarin who have severe bleeding and are unable to tolerate fresh or receive fresh frozen plasma, or in those in need of urgent reversal, the following should be considered: 4-factor prothrombin complex concentrate, or 3-factor prothrombin complex concentrate plus recombinant activated factor 7. And this ends the platelet and the coagulation disorders. We move to myeloid hematological malignancies. As an overview, myeloid hematological malignancies are among the most common malignancies in older adults, and they usually include acute myeloid leukemia or AML, myelodysplastic syndromes, myeloproliferative neoplasm, and combined myelodysplastic and myeloproliferative disorders. Transformation to acute leukemia is a concern with all myelodysplastic and myeloproliferative disorders. If we start with the myelodysplastic syndromes, they are a very heterogeneous collection of stem cell disorders characterized by disordered hematobiases and thrombocytopenias occurring mostly in older patients. The WHO classifies them as myelodysplastic syndrome with a single or multilineage dysplasia, myelodysplastic with a ring sideroblast, 5q syndrome, which is deletion of the long arm of chromosome 5, excess blast, and unclassified. Treatment options include chemotherapy, and in selected individuals, transplantation, which is need referred to a hematologist. If you go to the CML, it's a group of myeloid disorders common on older adults. CML could be including or encompassing chronic myeloid leukemia, polycythemia vera, essential thrombocythemia, idiopathic myelofibrosis, or many other stem cell mutations. The cytogenetic abnormalities in the cell clones that drive the malignant process associated with the extramedullary hematobiasis, resulting in organomegaly and increased blood cell count. The hallmark is the bone marrow hypercellularity, with overproduction of usually more than one bone marrow lineage, with a thrombotic and hemorrhagic diseases. The diagnosis of polycythemia vera, essential thrombocythemia, and it usually depends on the identifying the clonal markers. Usually JAK2 V617F is present in about 95% of patients with polycythemia vera, and about half of the patients with essential thrombocythemia. And common treatment approach is usually in the CML, we can give tyrosine kinase inhibitors such as imatinib, and also in the polycythemia vera, we can do serial phlebotomy for the symptoms, and also for the essential thrombocythemia, aspirin, and in some cases hydroxyurea is given for both for essential thrombocythemia and polycythemia vera. Raloxatinib, which is a JAK2 inhibitor, is approved for the symptomatic patient with polycythemia vera, IMF, or myelofibrosis developing as a result of essential thrombocythemia or polycythemia vera. As a summary, the hematopoietic reserve capacity of the bone marrow diminishes with advancing age. Anemia of the chronic disease is commonly multifactorial. Molecular assay may help in the diagnosis of an unknown anemia if standard evaluation is unrevealing. Coagulation enzyme activities increase with advancing age, increasing the risk of thrombotic events. The aging bone marrow has propensity to develop myeloid clones and hence malignancy. And that's conclude our presentation. If you guys have any question, I'll be very happy to answer along with Duaa. And then after that, we can move to the cases. Is there anyone who have a question? Hello? Hello?
Yes, we can hear you, Rufida.
Okay.
I don't think, yeah. I don't
Okay.
have a question.
Okay. So if there is no one have a question, let's move to the cases. And we start with a 71-year-old man who comes to the office because of a fatigue that was worsened over the past year. He has had no chest pain, shortness of breath, change in weight, or edema. The patient has a history of diabetes, hypertension, and hyperlipidemia. The patient is on metformin, lisinopril, and atorvastatin. On examination, the blood pressure is 148 over 65, heart rate is 72, respiratory rate is 14, BMI is 28. The conjunctiva are pale, and all other findings are normal. So the lab finding, his hemoglobin is 9, hematocrit is 28, MCV is 101, reticulocyte counts are 27,000. Methylmalonic acid is increased, serum homocysteine level is increased, normal white blood cell and platelet, creatinine, potassium, liver function, and thrombotropin findings are all normal. Normal folate and B12 level, and peripheral smear shows hypersegmented neutrophils. So regarding the diagnosis, which of the following the most likely cause of this patient anemia? Is it B12 deficiency? Is it myelodysplastic syndromes? Is it homocystinemia or folate deficiency? Okay, so let me go back to the chat. And okay, we see A and B and A. Okay, so you guys are correct. It is A, it's B12 deficiency, as the patient does have macrocytic anemia with high MCV. And at the same time, there is increase in the methylmalonic acid and the homocysteine. And also as a risk factor, the patient is already on metformin. And although the folate and B12 are normal, also we have the hypersegmented neutrophils is more specific with the macrocytic anemia of folate and B12 deficiency. So it is B12 deficiency. Let's move to the second case. We have a 72-year-old woman comes to the office for routine evaluation. She feels well. She has a history of rheumatoid arthritis diagnosed 20 years ago. She takes dose of methotrexate weekly. She feels that her arthritis is well controlled. On examination, her vital signs are normal. Her BMI is 21, and there is no active synovitis. Regarding her lab, her WBCs are 7,800, platelet are 345, and hemoglobin is 10. Her hematocrit is 32, MCV is 82. Her ferritin level is 350 nanogram. Her serum ion concentration is 25 microgram. TIBC is 220. ESR is 40. Normal creatinine, glucose, and thyrotropin levels. And her liver function test is normal. Which of the following the most likely cause of her anemia? Is it anemia of chronic disease or chronic inflammations? Is it iron deficiency anemia? Is it methotrexate toxicity or myelodysplastic syndrome? Let's see the chat. Okay. All right, I guess most of you are right. It is anemia of the chronic inflammations. It is correct. So let's move to the third case. We have a 78-year-old man comes to the office for routine evaluation. He stated that he feels well. He has smoked 2 packs of cigarette daily for the past 55 years. On examination, his blood pressure is 155/75, heart rate is 66, oxygen saturation is 91 on a room air. The BMI 32. Some redness is evident on the patient cheeks. Okay, so regarding his lab, it's his hemoglobin is 19, erythropoietin is 2, international unit per ml, normal white blood cell and platelets, normal creat, glucose and thyroid levels and liver function test, everything is normal. Which of the following studies is the most appropriate next diagnostic step? Is it genetic testing? Is it overnight sleep study? Is it magnetic resonance imaging of the abdomen and the pelvis? Is it bone marrow aspiration and biopsy? So the answer is, okay. 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 All right. So if we go to the answer, actually the right answer is A, because if you look like most of the other things could cause polycythemia, but if you look at the erythropoietin level, it's usually 2 international unit, which means that's not a secondary polycythemia, it's more of a primary polycythemia. And the genetic testing looking for the JAK2 mutation could be revealing that this is actually a primary polycythemia. Okay, so it's genetic testing. And that's it for the first presentation.
I have a question.
Mhm.
Hi, my name is Marina Das. I joined in new today.
Hello.
Yeah, thank you, Dr. Nadir, for adding me. I had a question. Does primary polycythemia present that late, like in 78 years of age?
Yeah, actually it does. It's usually, yeah, it could be a disease of young, but also can present in the elderly. So if you look at the whole picture, the patient, yes, does have a polycythemia, but since the erythropoietin is very low, this indicates that the problem is actually a primary rather than secondary, rather than having a lung condition or a tumor that's producing erythropoietin. So as a primary diagnosis, we can consider all of the other options, but for this patient specifically, genetic testing would be more helpful. And we can also see what does Dr. Nadir have to say about it.
No, I
Usually,
do agree with you. Yeah, go ahead, Dr. Ra.
thank you.
Thank you.
Usually, it's a genetic disorder, yes, and it's always there, but commonly it presents after the age of 60 because it develops very slowly and often not diagnosed until after the age of 60.
Thank you so much.
Okay.
If you have any.
Thank you both presenters, Dr. Ra and Rufida. Thanks.
Thank
We can
you.
go to the next topic.
Okay. So next we have Dr. Duaa. Let me share my screen for her. Dr. Duaa, Dr. Sara, I'm sorry. Dr. Sara, are you around?
Yes, I am here.
Okay, so let me share my screen for you. Okay. 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 So, okay.
Hello, everyone. This is Dr. Sara Atigo, and I'm going to present today how to develop a quality research article and avoid journal desk rejection, abstract, or manuscript submission.
Mhm. Can you see my my screen?
Yes, I can see it.
Okay.
Okay, when we are writing a good quality research article, there is some important point we should put in the consider. Like, why is good writing important? Science is complex, but the writing used to describe it need not to be good writing, is simple writing. High quality simple writing should have the following criteria, or increase your chances, increase the chances of acceptance for publication, and increase the impact of manuscript in research community, accelerate understanding and acceptance of the research, increasing the faith of readers in the quality of the research, and poorly written and complicated manuscript annoy readers, peer reviewers, and journal editors, and hinder their understanding of complicated scientific concepts. What do journal editors want from you? Journal editors evaluate submission and consider peer review advice. It is the journal editors who make the final decision about what gets published. Therefore, it is important to know how they make their decisions. Journal editors want to publish a good quality science that is of interest to their readers. They often must decide between many high-quality manuscripts. Your submission is more likely to be accepted if it describes research that advances the field, is carefully prepared and formatted, and uses clear and concise language, and follow ethical standards. Before you begin, you need to formulate the following: the study design, the reference manager, and choose a target journal. Okay, about the study design, you must have a good study design to get publishable result. When designing an experiment, you will need to decide what is your hypothesis or research question, and what are the aims of your study, and what are the best methods for achieving your aims, and do you have a necessary resource to carry out your methods, and which positive and negative control will you use. Do you have required ethics and regulatory permission? For example, if your experiment will have human subject, you will probably need the approval of the IRB. Will your experiment have enough statistical power to give a useful result? Is your sample size large enough to draw a valid conclusion? And which statistical test will you use for your analysis? If you are not sure, consult a statistician, and they can provide you with expert advice that may save you a lot of time. Reference managers. Reference managers or reference formatting software make it easy to organize and format citations. They can also assist with managing libraries containing citations, PDF, and imaging file. This allows you to organize important manuscript by subject and search your library using keywords. This will help you remember to appropriately cite manuscripts that you had read. Some widely used reference management and formatting software application are these examples like BibTeX and EndNotes and Papers and so on. When using reference manager, make sure you have the correct style file for your target journal. Formatting references uses reference manager with a style file is very simple. You can find specific instruction on formatting reference and style file for BMC in the journal submission guidance. And the BMC is the journal which is going to publish your research. Tips for finding the right journals. Submitting a manuscript to unsuitable journal is a common mistake and can cause journal editors to reject the manuscript before peer review. Choosing a relevant journal makes it more likely that your manuscript will be accepted. Some factors to consider are the topic the journal publish. If your research is applied, target a journal that publish applied science. If it is clinical, target a clinical journal. If it is basic research, target a journal that publish basic research. You may find it easier to browse a list of journals by subject area. The journal items will researcher in the related field be interested in your study? If so, a journal that covers a broad range of topics may be best. If any researcher in your field are likely to want to read your study, then a field-specific journal would be the best. And third, the type of the article the journal publish. If you are looking to publish a review, case study, or theory, ensure that your target journal accepts this type of manuscript. The repetition of the journal. A journal impact factor is one measure of its repetition, but not always the most important. You should consider the prestige of the authors that publish in the journal and whether your research is a similar level. And last, what are your personal requirements? Does the journal usually publish article quickly? And is the time to publication important for you? And then when looking for a suitable journal in which to publish your own result, start with what you have read. You should already be familiar with published studies that are similar to yours. Which journal were those studies published, and the same journal may be appropriate for your manuscript. So make a list of them. If you need more journal to consider, you can do literature search for other published articles in your field that are similar in scope and, and impact on the field, and see where they were published. When you have a list of potential target journals, visit and read the website for this journal. Every journal should have a page that provides submission guidelines, include information on many of the factors listed above. Journal on your list that are not matched to your manuscript based on the factor listed above should be eliminated from the consideration. Among the remaining journals, it is likely that one or more will stand as a very good candidate. Consider it if any additional experiment will give you a publication. If you are in hurry to publish, consider which of the remaining journal after rapid publication. If none, do consider which have the highest publication frequency. If your main goal is to read as many readers as possible, strongly consider candidate journals that has provided an open article, an open access option. Sorry. Open access allow everyone to read your article free of charges online, which can make your article more likely to be read and cited. When you have chosen the journal you think it is best fit for your study and your goal, it is usually a good idea to also identify your second and third choice journal. That way, if your paper is rejected from your first choice journal, you can quickly submit to your second choice journal. Second, transfer. If you have a different choice of journal published by BMC, you should submit to your first choice journal for consideration. If the editor decides that your manuscript is unsuitable, you can ask the editor about transferring your manuscript to another journal published by BMC. This transfer process means you do have to upload your manuscript file and details more than once. When there is a second choice journal that you like to same publisher, the manuscript and often the reviews can be transferred on your behalf. This can save time for authors, reviewers, and editors. However, you must never submit the same manuscript to more than one journal at the same time. Authorship. Authorship provides credit for researcher contribution to study and carries accountability. Authors are accepted to fulfill the criteria below. Proceeding of the National Academy Science. This is the criteria. Each author is expected to have made substantial contributor to the conception or design of work, or the acquisition, analysis, or interpretation of the data, or the creation of new software used in the work, or have drafted the work or substantively revised it. Plus that, we need to have approved the submitted version and any substantially modified version that involves the author contribution to the study, and to have agreed both to personally accountable for the author's own contribution, and to ensure that questions related to the accuracy or integrity of any part of the work, even ones in which the author was not personally involved, are appropriately investigated, resolved, and the reasons documented in the literature. BMC journal encourage collaboration collaboration with colleagues in the locations where the research is conducted and expect their inclusion as co-author when they fulfill all authorship criteria described above. Contributors who do not meet the criteria for authorship should be listed as acknowledged main section. Please see individual journal submission guideline for information on the format for the listing author contribution, and author wishing to make changes to authorship will be asked to complete our form. Please note that changes to authorship cannot be made after acceptance of the manuscript. Corresponding author. Corresponding authors are responsible for ensuring that all listed authors has approved the manuscript before submission, including the name and the order of the authors, and that all the authors receive submission and the substantive correspondence with editor, as well as the full reviews, verifying that all the data, figures, materials, including reagents and code, and even those developed or provided by other authors, comply with the transparency and reproducibility standard of both and field, the field and the journal. This responsibility include, but not limited to, ensuring that original data, original figures, material, code upon which the submission is based are preserved following best practice in the field so that they are retrievable for analysis, and confirming that data, figures, material, code presentation accurately reflect the origin, and also foreseeing and minimizing obstacle to the sharing of the data, material, and code described in the work. The corresponding author should be responsible for managing this requirement across the author group and ensuring that the entire author group is fully aware of and compliance best practice in the discipline of the publication. To discourage ghost authorship, corresponding author must reveal appropriate whether the manuscript benefited from use of editorial service. If acknowledged it might constitute an undisclosed conflict of interest. Example, include use of an editors from an organization that may have a vested interest in standing as a result or reliance on technical writers at levels that would warrant authorship credit. This situation might variously be addressed by including a statement in the acknowledgement, by describing the effort of the method section, or by adding an author, another author. The involvement of scientific medical writers or anyone else who assisted with the preparation of manuscript content should be acknowledged, along with their source of funding, as described in the guideline. The role of the medical writer should be acknowledged explicitly in the acknowledgement or author contribution section appropriate. Corresponding author should indicate whether any author or earlier version have been removed or new author added and why. It is incumbent on the corresponding author to ensure that all authors or group laboratory leaders in the lab collaboration have certified the author list and contribution description, that all authors who deserve to be created on the manuscript are indeed identified, that no author are listed who do not deserve author credit, and that author contribution, whether they are provided and expressed accurately. Any potential dispute brought to the editor's attention will be handled in the line of COP guidelines. Acknowledgement. All contributors who do not meet criteria for authorship should be listed in the acknowledgement section. Example of those who might be acknowledged include a person who provided a purely technical help or writing assistance, or department chair who provided only general support. Third-party submission. All manuscripts must be submitted by an author and may not be submitted by a third party. Okay, how to structure your manuscript. Overview of article structure. Details on the structure of manuscript published in PMC journal can be found in the instruction for the authors for each journal. The standard structure of the body of the research article after the title and abstract is you should have background, methods, results, discussion, and conclusion. Besides that, the article structure should give the logical flow to the content, makes journal manuscript predictable and easy to read, and provide maps so that readers can quickly find content of interest in any manuscript. Remind author what content should be included. But also the section of the journal manuscript are published in the orders: title, abstract, backgrounds, and methods, result, discussion, and conclusion. This is not the best order for the writing the section of manuscript. One strategy to write your manuscript is the following orders: materials and methods, and then results. This can be written first. As you're doing your experiment and collecting the result, then you should put like introduction, discussion, conclusion, and write this section next once you have decided on your target journal, the title and the abstract. Write your title and abstract based on all of the other sections. Following this order will help you write logical and consistent manuscript. Use the different section of manuscript to tell a story about your research and its implication. It is important that your manuscript give a clear and complete account of research that you have done. Well-reported research is more useful, and complete reporting allow editors and the peers and the readers to understand what you did and how. Poorly reported research can distort the literature and lead to research that cannot be replicated or used in the future meta-analysis or systematic reviews. You should make sure that your manuscript is written in a way that reader knows exactly what you did and could repeat your study if they want to with no additional information. It is particularly important that you give enough information in the methods section of your manuscript. To help with reporting your research, there are reporting guidelines available for many different study design. These contain checklist of minimum points that you should cover in your manuscript. You should use this guideline when you are preparing and writing your manuscript, and you may be required to provide a completed version of the checklist when you submit your manuscript. The equator enhancing the quality and transparency of health research network is international initiative that aims to improve the quality of research publication. It provides a comprehensive list of reporting guidelines and other material to help improve reporting. A list of all of the reporting guidelines endorsed by the Equator Network can be found here, like if you want to do it. And some of the reporting guidelines for common study designs are, it could be either a randomized control trial and a systematic review and observational studies, case report, qualitative research, preclinical animal studies. Peer reviews may be asked to use this checklist when assessing your manuscript. If you allow these guidelines, editors and peer reviewers will be able to assess your manuscript better, as they will more easily understand what you did. It may also mean that they ask you for fewer revision. Writing titles and abstract. The titles and abstract are most important part of your article. During peer review, the title and abstract are used when we invite interviewers. Invited interviewers are asked to decide whether they wish to review the manuscript on the basis of the title and abstract alone. If and when the manuscript is published, more people will read the title and abstract than the whole article. In fact, many people will only read the title and abstract, and many may only try to read them once. It is thus important to catch the reader attention by making the title and abstract is concise, accurate, readable as possible. Most people rely on electronic search engines to find articles. Usually they search through database that contain only the title, author list, and abstract of article, excluding any key word attached to the article by its authors. This is the case, for example, for the National Library of Medicine database, include Medline and PubMed. It is therefore important to include in the title or abstract the words that potential readers of the article are used during search. If you want to make sure that your article is found as a related article in a PubMed searches, please bear in mind that the algorithm used for this functionality gives more weight to less common terms, words used more frequently within a document, and terms in the title. Title are the key to ensuring your article will be found. The title is an essential way to bring the article to potential readers' attention, especially in those cases where the database being searched does not include the abstract of the article. The title must therefore be as accurate, informative, and complete as possible. Some tips on the title. Be as descriptive as possible and use specific rather than general terms. For instance, includes the specific drug name rather than just the class of the drug. Secondly, use simple words, orders, and common words combination. For example, juvenile delinquency is more commonly used than delinquency among juveniles. Avoid using abbreviation. They could have different meanings in different fields. Avoid using acronyms and initialism. CA for calcium could be a mistake for CA, which means cancer. Write scientific names in full. Instead of E. coli, we should write Escherichia coli. Refer to chemicals by their common generic name instead of their formulas. Avoid the use of Roman numbers in the title as they can be interpreted differently. For instance, bar 3 could be mistaken for factor 3. Abstract, selecting the most important information. The abstract must outline the most important aspect of the study while providing only a limited amount of detail on its background, methodology, and results. Authors need to critically assess the different aspects of the manuscript and choose those that are sufficiently important to deserve inclusion in the abstract. Once the abstract is ready, it can be helpful to ask a colleague who is not involved in the research to go through it to ensure that the descriptions are clear. After the manuscript is written, the authors should go back to abstract to check that it agrees with the content of the final manuscript. Abstract structure. Abstract structure should have a structure format. This serves several purposes. It helps authors summarize the different aspects of their work. It makes the abstract more immediately clear, and it helps peer reviewers and readers assess the content of the manuscript. The abstract structure varies between journals and between type of article. Authors should check that the abstract of their manuscript is consistent with the requirement of the article type and the journal to which the manuscript will be submitted. Please note that the abstract requirement differ between the biology and the medical journal in the PMC series published by PMC. For example, the abstract of manuscript submitted to the biology journal in the PMC series should be structured as follows. The background, This should place the study into context of the current knowledge in its field and list the purpose of the work. In other words, the author should summarize why they carry out their research results. This section should describe the main finding of the study. And the conclusion, a briefly summary of the content of the manuscript and the potential complication of its result. The abstract of the manuscript submitted to the medical journal in the PMC series should be structured as follows. The background, the method, the result, and the conclusion. The background, result, and conclusion are for the biology journals above. In addition, the method section should summarize how the study was performed and mention the different techniques employed. It should also include details of many statistical tests employed. For further details on the requirements of any article journal published by PMC, please, you can use this link. Some tips on writing abstract. Check the abstract length. Abstract should not exceed 50 words. Abstracts that are too long lose their function as summarized of the full articles, and excess word may be omitted by some indexing service. Includes synonyms for the words and concepts that are in the title. If referring to stillbirths in the title, mention perinatal death in the abstract if appropriate. As in the title, use simple word orders and common word combination. Make sure the salient point of the manuscript are included, but be consistent. The abstract should only reflect those points covered in the manuscript. Minimize the use of abbreviation and avoid citing references. Rufida, if you can make it bigger.
Sure.
Thank you.
Is it good?
The background, yes. The background should provide readers with the information needed to understand your study and the reason why you conducted your experiment. The background should answer the question. What question problem was studied? While waiting the background, make sure your citations are well balanced. If experiment have found conflicting result on a question, have you cited a study with both kind of result? Concurrent, every field is different, but you should aim to cite references that are not more than 10 years old if possible. Relevant, this is the most important requirement. The study you cite should be strongly related to your research question. Do not write literature review in your background, but do cite review where readers can find more information if they want to. Once you have provided background material and stated the problems or question for your study, tell the readers the purpose of your study. Usually the reasons is to fill a gap in the knowledge or to answer a previously unanswered question. For example, if a drug is known to work well in one population but has never been tested in a different population, the purpose of the study could be test the efficacy and safety of the drug in the second population. The final thing to include at the end of your background is a clear and exact statement of your study aims. You might also explain very briefly how you conducted the study. Then the result. Some journals may allow result and discussion to be combined. The result and the discussion section may be broken into a subsection with short, informative headlines. For further details, you can check the journal instruction for author page. As the methods section, use subheadings to separate the result of different experiments. Results should be presented in logical orders. In general, these will be in orders of importance, not necessarily the orders in which the experiment were performed. Use the past tense to describe your results. However, refer to figures and table in the present tense. Do not duplicate data among figures, tables, and tests. A common mistake is to restate much of the data from table in the text of the manuscript. Instead, use of the text to summarize what the readers will find in the table or mention one or two of the most important data points. It is usually much easier to read data in a table than in a text. Include the results of statistical analysis in the text, usually by providing p-value whenever statistical significance differences are described. Data presentation, content, figures, table, and other display items are often the quickest way to communicate a large amount of complex information. Many readers will only look at your display items without reading the main text of your manuscript. Therefore, choose a design your figures and tables very carefully so your manuscript communicates well with the readers. Display items are also important for attracting readers to your work. Attractive display items will hold the items of readers and compel them to take time to understand the figure. Finally, high-quality display items give your work a professional appearance. Readers will assume that a professional-looking manuscript contains professional-done science. Thus, readers will be more likely to believe your result and your interpretation of these results. The advice below include detailed information that is specific to BMC journal for formatting display items, illustration and figures, and guideline for the cropping of figures. We are going to go through each of them. Okay, illustration of figures. This section provides general information for authors creating figures to maximize the quality of those illustrations and to prepare artwork for submission to PMC journals. Guidelines on a specific type of figures and supported file formats are also available for the relevant journals. PMC encourage authors to use figure where this will increase the clarity of an article. The use of color figure in article is free of charge. BMC Journal published article in a typeset final PDF version and full text web version within a few days of acceptance. In the author PDF, figures are included sequentially at the end of the article, one to a page. Figures in the full text web version of an articles are linked directly from the text each time they are mentioned and open in a new window. In the typeset PDF, figures are placed appropriately within the text as close as possible to their first mention in the text. Most BMC journals do not redraw author provide figures. It is the author's responsibility to ensure that figures are provided as sufficiently high resolution to ensure high quality reproduction in the final article. Production of the final full text web and PDF version will proceed more quickly if authors submit figures in accordance with BMC guidelines as specified in this document. Preparing figure file for submission. Illustration should be provided as a separate file, not embedded in the main manuscript file. Each figure of the manuscript should be submitted as a single file. Tables should not be submitted as figures, but should be included in the main manuscript file. This, as an example, multi-panel figure, those with part A and B and C and extra should be submitted as a single composite file that contain all the parts of the figure. It shouldn't submit it like individually or separated. Figure titles and links should be provided in the main manuscript, not in the graphic file. And also figures should be numbered in order they are first mentioned in the text and uploaded in these orders. For example, the one on the left is wrong, and the one on the right is an example of the right one. Figure should be uploaded in the correct orientation. Individual figure file should not exceed 10 megabytes. If a suitable format is chosen, this file size is adequate for extremely high quality figures. Please note that it is the responsibility of the authors to obtain permission from the copyright holder to reproduce figure or tables that have previously been published elsewhere. In order for all figures to be open access, author must have permission from the rights holder if they wish to include images that have been published elsewhere in the non-open access journal. Permission should be indicated in the figure legend and the original sources included in the preference list. Detailed guidelines will be found in this link. Useful software. There are many software packages capable of converting to and from the major graphic format. Good general tools for image conversion and enhancement include Adobe Photoshop and Graphic Converter and Paint Pro. A variety of cross-platform open sources software is also available for this purpose, including like Magic and GIMB, and each of these package runs on Mac, Windows, and Linux. This last thing is the example of the file format. It should include all of this. And this is another file format. Yeah. Additional file format, it should include additional documents and algorithm, and animation and movies. Animation can be provided in SWF Swift Shockwave Flash format for converted in a video format, and the audio and the chemical structure and the computational models and generic data files and geospatial data.
Okay.
And that was the topic. I know it is a very long topic and have a lot of details. Maybe Dr. Nadir can give us like a summary, or so everyone can benefit from this presentation.
Thank you very much, Dr. Sari, for the presentation. Dr. Nadir.
Thank you so much. This is great. I think to the point. Thank you so much.
Yeah, welcome.
So next in the agenda, we have Introduction to ANOVA. It's going to be presented by Dr. Lena Alomeiri. Dr. Lena, are you around?
Good afternoon, everyone. Can you see my slides?
Yes, we can see it, Lena.
Just let me figure out how to make it a presentation.
Yes.
Okay. So good afternoon, everyone. I'm Lena Alomeiri. I will be presenting a gentle introduction to ANOVA. The significance of the difference between two sample means can be judged through either Z-test or T-test. The Z-test is applied to find out the degree of reliability of the statistic in case of large samples. It's based on the normal probability distribution and used for judging the significance of several statistical measures, particularly the mean. On the other hand, the T-test is used to test the null hypothesis that the population means of two groups are the same. It's commonly used with small sample size to test the difference between them when the variances of the two are of normal distribution and are not known. So the T-test is used also for judging the significance of the coefficient of simple and partial correlations. It's possible when we have more than two means, as we have more than two groups, to compare each mean with each other using T-tests. But this leads to the problem of conducting multiple T-tests causes inflation of type 1 error. So what's type 1 error? Also known as false positive. It occurs when the researcher rejects a null hypothesis that is actually true in the population. As for inflation of the type 1 error, every T-test has a p-value of 0.05 chance of being type 1 error. Rejecting the null hypothesis in multiple T-tests on the same data increases the probability of type 1 error. Here we have a small example. Suppose that we have a paper suggesting that exercise for 2.5 hours a week with moderate aerobic activity. And we have three groups. We have a control group, a group that exercises for 2.5 hours, and a third group exercising for 5 hours per week. So if we want to compare the means of these groups, we have to compare each two groups together. So we have group A with group B. This has alpha value of 0.05. Then we have group B with group C, also 0.05 alpha value. And we have group A and group C. For each of these comparisons, we have an error chance of 0.05. So what's the problem? Imagine you are going to play lottery. You have 20 tickets, and you are going to buy each for $10. Between those 20 tickets, the price is about $1,000. What should you do? Ideally, if you want to win 100%, you should buy the 20 tickets, all of them. This will guarantee you winning the prize of $1,000. So any ticket has 5% chance, a b-value of 0.5, of winning. One of them will certainly be a winner. In this same logic, if you apply T-test several times, at the end, you are going to commit a type 1 error. The more you apply a T-test, the more the chance of committing type 1 error. For this reason, we are going to use ANOVA. ANOVA is used to test differences among several means for significance without increasing the type 1 error rate. So what's ANOVA? ANOVA, or analysis of variance of groups to assess differences in means between groups. It's also an extension of regression, also known as the general linear model, or GLM. It enables us to perform this simultaneous test, and in such, it's considered a very valuable tool for researchers. The essence of ANOVA is that the amount of variation in a set of data is broken down into two types. The first type, or amount, which can be attributed to chance, and the second amount, which can be attributed to specific cause. Assumptions of ANOVA. Several assumptions should be there for ANOVA to work. First of all, the experimental error of data are normally distributed. We have equal variances in each sample, which is homogeneity of the variances. The third assumption is that independence of the sample. Each sample is randomly selected and is independent of each other. Here we have the types of ANOVA. Depending on how many factors being tested, we can classify an ANOVA for one-way ANOVA, two-way ANOVA, three-way ANOVA, and more. One-way ANOVA is also called single factor ANOVA. The t-test is the simplest type of ANOVA in which only one source of variation or factor is investigated. It's an extension of 3 or more samples of the t-test procedure for use with independent samples. In another way, t-test for use with 2 independent samples is a special case of one-way ANOVA. Here we have an example of one-way ANOVA. Suppose we have 3 groups, hypnotized, non-hypnotized, and drunk. And we want to test each group how many number of words they can recall. So our question is, do hypnotized participants remember more words than the unhypnotized or drunken participants? This example is an example of one-way ANOVA. Two-way ANOVA, on the other hand, is used to determine the effect of 2 nominal predictors or variables on the continuous outcome variable. So what's the difference between one-way and two-way ANOVA? In one-way ANOVA, we have 1 independent variable. In two-way ANOVA, we have 2 independent variables. In one-way ANOVA, we have only 1 b-value to obtain. In two-way ANOVA, we have 3 different b-values to obtain. Here I'm going to give a small introduction to the steps in calculating ANOVA. I'm going to use this table to demonstrate a one-way ANOVA table. So the first step in conducting ANOVA is calculating the degree of freedom between first the groups and next within the group and the total degree of freedom. As we see here, the degree of freedom between groups is k minus 1, k being the number of groups we are testing. Suppose we have 3 groups in our example, the degree of freedom would be 2. The second step is the degree of freedom within the group, each group. It's n minus k, n being the number in each sample, and k the number of groups. And the total degree of freedom being n minus 1. Using equations, we're going to calculate the sum square first between groups, after that within each group, and the total sum of squares. After that, we calculate the mean square between groups also and within group. Here it gets easier after using the equations to calculate the sum squares. Mean square for between the groups equal sum of the squares between groups divided by k minus 1, which is degree of freedom between groups. So we just divide the two neighboring cells on each other. Within mean square of within the group also equals sum of squares within group divided by degree of freedom within group, also the two neighboring cells in the table. The last step is calculating the F ratio, which is the two cells in mean square, MSB, divided by MSW, mean square between groups, divided by mean square within groups. The final step after getting the F value is comparing it to the statistical tables and see if our absolute value is greater than the critical value. The value we calculate is greater than the value in the table. We reject the null hypothesis and conclude that there is significant difference between the means of the population. Otherwise, if not, we accept the null hypothesis and fail to reject the null hypothesis. So I'm going to go back and speak briefly about each step. The first step is calculating the means. You need to calculate all the means for all the groups in question. Then you also need to calculate the overall means with all the data combined together as one group. Create or set your null and alternative hypothesis and the alpha power. Calculate the degree of freedom, as we said. Calculate the degree of freedom in each group and between groups. Then we are going to square everything up. We're going to calculate mean squares within groups and between groups. At the end, we were going to create a summary table and calculate the F statistic. The last step is compare the results with the pre-existing tables and decide if we are going to reject the null hypothesis or not. And that's it for my brief presentation. If you have any question, just feel free to type it up or say it in person.
Thank you very much, Dr. Lena, for the presentation. If anyone have a question, let's know so that Dr. Lena can answer. If not, we can move to Dr. Hammad. Okay, so our next presenter is going to be Dr. Hammad. If you're ready, Dr. Hammad, you can start.
Let me just stop screening.
Okay.
Hello.
Hello.
Hello. Yes, I am Dr. Hammad. Yes, I am ready.
Okay, you can proceed.
Yeah. First, really thank you for this opportunity to present this presentation, and thanks to Dr. Nader. Actually, I attended this lecture 3 days or 4 days ago. Okay, it was about role of acute care prescribing avoid epidemic. I took some notes and I would like to give some ideas about this topic. This one was presented by Mr. Chad. It was speaking about the role of the medicine that prescribed by us, by physicians, by surgeons, okay, in patient post-operative, and how does it contribute to the epidemic of opioid. As you know, all of you, okay, most of the patients or the drug abusers, they get their medications or their substance from the street. But that was before. Now it changed a little bit at least. Okay. In this one, we are going to briefly discuss the risk of post-operative opioid prescribing. This describe risk factors for persistent post-operative opioid use. Examine evidence-based methods to reduce risk related to post-surgical opioid prescribing. The first slides
Dr.
are
Hammad,
only speaking about the organization
sorry to
who
interrupt
hosted
you.
this.
Do you
Hello?
have the slides? Can you share the screen? Because I don't think we see.
Sorry.
No worries.
Okay.
Thank you.
Hello, do you hear me?
Yes, we
Yes.
can hear you, and your screen is clear too.
Okay. This is the presentation. Okay. It was speaking about the role of acute care prescribing in opioid epidemic. Okay, just like I said, this presentation was about how does the us physician contribute to the epidemic of opioid. How does prescribing opioid for patients, okay, now is considered a cause of substance abuse. Actually, it is not intentional, okay, but we need to just to organize our prescription to make sure we don't bring more patients to this spectrum of disease. In this presentation, I'm going to discuss briefly the risks of post-operative opioid prescribing, describe risk factors for persistent post-operative opioid use, examine evidence-based methods to reduce risk related to post-surgical opioid prescribing. The first slide, just like I said, are about the organization who hosted the presentation. Okay. Okay. First thing, okay. We are going to speak about the opioid epidemic. When we speak about this epidemic, we can consider it as a crisis because it is on rising and it has fatal outcomes. Opioid overdose kills more individuals than those involved in fatal RTAs, motor vehicle accidents. And in USA, only 205 Americans die every day from opioid overdose. That includes prescription opioid and heroin. What I mean is that even the prescription that the patient gets from the physician or surgeon also contribute to the death of the patient, not intentionally, okay, but just I wanted to clarify this statistic. They are just like in the time where they wrote a topic saying they are the most powerful painkiller ever invented and they are creating the most addiction crisis America has ever seen. Okay. If you are going to prevent chronic opioid use and misuse, okay, we have to prevent before it stops. Okay. Chronic opioid use, okay, and it is diversion into the community. Eventually, it will lead to opioid epidemic. What does that mean? That means that we have to reassess the patient every time they come for refilling, okay, in the clinic. Okay, we should tend to make patient not a chronic users, okay, because this will lead to it is more distribution into the community. Eventually, this will contribute more to opioid epidemic. If we manage to stop this, most likely it will lead to reduce of epidemic of the opioid. Why do surgeons prescribe too much? Some people will be surprised with the reason, but most of you, as you know, okay, we have one of the line of management which is called pain control, even before pre-operative and post-operative. Pre-operative, like if patient presents with cholecystitis, the pain will be severe and the patient will not be able to tolerate. In addition to the inflammation and the status of his body, we have to administer opioid and strong painkillers just to make the patient feels better. One of the reasons, okay, that the studies shows that surgeons tend to prescribe opioid just to have a calm weekend, so they don't get many calls about the pain on the weekend. from the patients, from the residents, telling them that the patient is experiencing severe pain. So in case the patient is not having that much pain and it is relieved by non-opioid medication, okay, the doctor and the surgeon will not tend to prescribe this medication because sometimes the pain unexpectedly will increase. Okay, and the prescribed medication, non-opioid medication, will not help to relieve this pain. So they will get more phone calls disturbing them at night. In addition to that, just to as a part of line of treatment, just like I said, and I mean, some people are saying just because they are generate more money, okay, and some people because they are just used to do that. Okay, when they have a patient like presenting with appendicitis or cholecystitis, we will prescribe immediately the pain killer as opioid without going through the non-opioid medication first. These are some reasons, okay, and they are not intentionally leading to the substance abuse. But now we are still showing that they are leading to be part of the substance abuse causes. Okay, we'll skip this one. Okay. Who is at risk for persistent post-operative opioid use? First, the patient who have chronic pain conditions like fibromyalgia and patients who have chronic conditions. Okay, some people they will start with the first line of medication, non-steroid anti-inflammatory drugs. They will use also tricyclic antidepressant, but eventually they will be referred to pain specialist. The pain specialist will assess the patient and eventually will start the patient on opioid medication. But patient will feel better, but they will not stop the medicine and they will continue because they feel their condition is only controlled with this medication. Substance use disorder. If a patient has a substance use disorder of another substance, they will tend more to become addicted on opioid. Like a patient who has cocaine abuse, okay, and admit to the hospital with surgical condition and given opioid, he most likely he will request more. From my experience, I saw patient presenting with MI. Next time when he present with a chest pain similar to his old presentation, later on turned out not to be MI, but he immediately he was shouting he wants morphine, and many times he wanted morphine. Even so, the pain score is less than 3, but he insisted on morphine because he was afraid. Okay, tobacco use also. Patients who are anxious and experiencing anxiety, patients who have mood disorders, patients who have sleeping problems, and also remote opioid use. Like this means that patients who use opioid without coming to the clinic by themselves, okay, and so they will have opioid to be prescribed, but without close monitoring. So for patients to receive opioid, there are many steps to be done before the prescribing the medication. They have to check the pharmacies, nearby pharmacies, the register. They have to sign an agreement with the physician and the patient that he is going to follow the prescription. He's not going to follow with another physician. He's not going to overdose. He's not going to do, okay? If the patient is not coming to the clinic, not receiving enough counseling about the use of opioid, when to use and when not to use, and how overdose can harm them, most likely they will tend to become abusers of the medication. Persistent opioid use is associated with negative outcomes. Like patient will become part of have opioid use disorder, will become addicted, asking for PCD, asking for morphine many times. Sometimes patient will develop overdose with serious health outcomes in his body. Some patient will not be able to live after the overdose, and some will die. Healthcare costs and utilization. Patients are also associated with increased risk of fall and also readmissions to the hospital for the side effects and overdose. Okay. This one, Michigan Surgical Quality Collaborative, okay, they were working on an initiative called OPEN, okay, in Michigan. Okay, they collected data, okay, from Michigan about places where most people who died from opioid overuse. Okay, eventually they said we have to do what is called open opioid prescribing engagement network. It is starting with new prescribing recommendations based on patient consumption, reduction leading to reduction in opioid prescribing, leading eventually in patient reduction in patient opioid consumption. Okay, we have to monitor satisfaction, and that one of the goals. Okay, to clarify the meaning, prescribing recommendation. It is this the updated version. Like if patient who have like thyroidectomy, he will receive oxycodone 5 milligram tablet from 0 to 5. He will not receive more than this. Okay, they will make the prescribing of opioid more standardized. It will not be according to the physician judgment, according to the case, to control the opioid prescribing to the patient. This one describes the timeline in which the open initiative was started. In 2016, first it was a presentation. The first guideline released in 2017. Okay, the second line followed after that by 1 year, and third guideline after that. It was associated with decrease in the opioid prescribing size, and it shows some benefits in controlling the prescribing of opioids. This one is showing the level of the prescribed medications and the consumption of patients after following the open initiatives. It shows that prescription of opioid medications decreased over the years since the release of the guidelines, and the consumption of patients. Okay, sometimes it fluctuates, but eventually it leads to a decrease in the level of the consumption by the patients. Yeah. Okay. The goals of open initiative is to reduce opioid use, eliminate unnecessary opioid exposure, educate provider, patients, and communities. Okay. The ultimate goal is to reduce the opioid use by the patients, and this will happen through education and counseling of the physician how to prescribe and the risk of prescribing and over prescribing the medicine by counseling the patient. Some patients are even referred to stay with the pain after counseling and explaining the side effect of the opioid, and also to educate the communities about the patients and about the people who are between us, who are sometimes described as opioid addictors. And this one, okay. Just this is the last slide. Okay, this was a summary and brief presentation of this presentation was presented by Mr. Chad about why we should avoid prescribing too much opioid medications for patients, how it is associated with unhealthy and deadly outcomes to the patients, and explaining the open initiatives, okay, initiated by them, okay, to reduce the opioid prescription in Michigan. It shows some benefit and success in controlling of the consumption of opioid by patients, and also the prescription of opioid by the physician. Thank you very much. Any question?
Thank you very much, Dr. Hammad. If anyone have a question, feel free to ask Dr. Hammad. If not, this was our last presentation. And then after this, we're gonna move to the project updates. Does anyone have a question to Dr. Hammad? All right. So from here,
thank you very much.
Move...
Thank you very much, Victor. Thank you.
Thank you, Dr. Hammad. So from here, we can move to the project updates. Anyone have an update or a question regarding the project that they're currently working in, feel free to unmute yourself and participate.
Yes, hi. I do have some, not questions, just sharing updates with Dr. Nader. Sorry about my voice. Can you hear me?
Go ahead.
Yes, Ladies, go ahead.
Yes, okay. So hi, Dr. Nader. So I sent you an email about the oral health application. And I promised that once I come back from the vacation, I'm gonna get you an update. So I think that the email that you last sent me to work on some things, I'm not sure if you took a look. I told you that I worked on them. So I think for now, like from my end, sorry. So I think from my end, from our end, like all the participants too, we reached like we don't know what to do from now on the project. Like, is there anything else we have to add for it?
So I will look. I didn't look at the last file you sent me, so I will look at that and edit if there is any addition or correction. And then the next step is to see which journal. So if you want to work on which journal we want to submit this manuscript to, that would be great. So
Sorry, what? Sorry, doctor, I couldn't hear.
Journal.
Journal, yes. Okay, yeah. So I did add like a small section to make it more user specific, because we are targeting like dentists or dental students. So what I added was like a section where they can add their patients, and then they can add like the drugs that the patients are currently taking, so that it will be easier for them to make sure what drug interactions can happen, like just list the specific drugs they have to be careful with. So that's what I added recently to the application. Yeah.
So I'll have a look at it again. Tell you. Thank you.
Okay.
Excellent
Okay,
work.
thank you, doctor.
Yeah.
Thank you so
Thank you
much.
so
Thank you so much.
Thank you so much. Go ahead, Dr. Lena.
Hello, Dr. Nader. I'm new student in your program. Just I want to thank you for accepting me as a new in your program. And I want to apologize today, like I came late because I faced like some technical problem. So just I interviewed. Thank you so much.
You're welcome. Yeah. Welcome aboard. Then followed by Dr. Ahmad. Go ahead.
Hello, Dr. Nader. I've joined new as well to the program, and I just wanted to introduce myself. I'm Hind Babakar, and I would like to thank you so much for the opportunity, and I'm looking forward to do a great work with you. Today was a great presentation, and I'm really glad that I have joined. Thank you so much.
Welcome aboard.
Hello.
Hello, go ahead.
Assalamu alaikum, Dr. Nader.
Alaikum salam wa rahmatullah.
I'm Roya from the dental group. I actually have update about our literature review on the effect of antihypertensive drugs on the elderly oral health. Would like to know your opinion on our literature review, if it's ready to publish or not yet. And thank you for those tips. It was very helpful.
You're welcome. So I'm gonna look at the file. I think you sent me the file or one of your team members. So I'll look at that and then give you feedback. And again, we'll look at which journal we're gonna submit to, and then we'll take it from there. Great job.
Okay.
Thank you.
Thank you. Thank you.
Go ahead, Dr. Rufida and Dr. Hammad.
Yes.
Hello. Yes, go ahead, Dr. Rufida.
It's okay. It's okay. Regarding the systematic review me and my team are working on, we already finished the data extraction, we did the quality assessment, and now most of the team like we divided the team into subgroups. So most of the subgroups, they are done with the data analysis. Only around one group is left. So maybe by this week, we're going to be able to write the abstract. And next week, if we have, like, if there is a time in the presentation, maybe we will be able, like, we're going to send it to you to give it a look. And then after that, we can present it next week if it's possible.
Sounds good.
All
Excellent,
right.
yeah.
Thank
Great.
you.
Thank you so much. Yeah.
Thank you.
So hello, Dr. Nader. Hi, everyone.
Hello.
I'm so excited to share with you our new application. We are done with the adult vaccination app. First of all, I would like to thank Dr. Nader for the great opportunity, and I would like to thank my team members who helped me achieve this in short amount of time. It would not have been possible without their help. So let's get into it. I hope you can see my phone screen. Is it clear? Okay,
Yes,
great.
we can see.
So our application is called VaxAware. We have two main features to this application. The first one is the information-based pages, and we also have a page where users can log their vaccination history. So let's get into it. So you are now familiar with the way that we are presenting our application. We usually start with the about the app page. And here we just included a brief description of our application and what are the special features about it and why you should download this app. And here we have the second page, which is the vaccine schedules. In vaccine schedule, this button is going to lead us to this page where we divided schedules into three main categories. The first one is the adult vaccine schedule, which includes the vaccination that should be received by an otherwise normal adult population. So let's get into it. So here we have this schedule. It includes all vaccinations that should be received by adults, going through like COVID-19, the flu, DTaP, measles, and up to like Haemophilus influenzae. And here we included all age groups, like 19 to 26, and then 27 to 49, 50 to 64, and 65 years or above. And creating this schedule was an interesting process because it required like a high degree of precision, but we really enjoyed that. So the second schedule is like vaccines according to this special medical condition. So for example, like we tried to list the most common comorbidities or most common conditions that require like specific type of vaccination or certain schedule, like pregnancy, diabetes, chronic liver disease, and so on. If we click on pregnancy, for example, it will give us a list of the most important vaccines that should be received for pregnant women. If we took COVID-19, for example, if we click on that, it will show us the importance of that vaccine and the doses required. And some vaccines, not all, we included a link where users can click on that link and it will take them to another page. Our reference for this application is the CDC website. For example, if I clicked on the link, like it will take me to the CDC website for further information about COVID-19 and pregnancy, because usually people ask about this. Would like COVID-19 vaccine affect my baby? And it's a very common question. That's why we included that link. So going back, and we have vaccines according to the special circumstances, like being a military personnel, healthcare workers, travelers, school, daycare workers, and homeless. So if I clicked on the military personnel, it will also show like in addition to age-appropriate vaccines, we have to give a specific vaccine, like meningococcal conjugate is very important for military personnel. And like we go the same way for healthcare workers, for travelers, and so on. So here, going to vaccine info. Here we just added for each specific vaccine the most important information that we think users should understand about like vaccine benefits, route of administration, side effects, and contraindications. And we continue with the same way with other vaccines as well. Here, this is the second main feature of our app, which is my vaccine history. In this page, users can log their vaccination history, and then they can share the entire history, or they can share a selected vaccine. So let's try this. For example, I took the Pfizer vaccine today, and it's my dose number 1. And if I'm going to write a note like maybe 1 dose remaining, or anything that the patient or the user would like to write. So, and then I'm going to click on add. As you can see, it added the date, the time, vaccination name, the dose number, and a note specific to that vaccine. And then if I want to share this, I can add another one, like maybe HIV, dose number 1 and 1 dose remaining, the same. And it will keep adding all the history, like for a limited, like we don't have a limited set for the history. Patients can add whatever vaccine they want, and then they can share all history or share a selected vaccine. If they click on this vaccine, for example, they can share the notes with the healthcare provider or with a family member. And then, yes, that's it. We have the disclaimer. This app is not going to replace professional medical advice, for sure. And of course, the copyrights. And those are the authors for this application. I would like to thank each and every individual who participated in creating this application. They helped me a lot and provided me with all the up-to-date information related to vaccines, and I just worked on the technical side of it. So thank you so much, Dr. Nader, for the great opportunity. Thank you so much for my team members, and thank you so much for your attention. So if you have any question or comment, feel free. Thank you.
Thank you for sharing this really great. I think you did great job and hard work, and hopefully it's going to be useful for users. That's great. Awesome.
Thank you so much, Dr. Nader. We really appreciate this opportunity.
Any other comments? Great job. So still we are working on different other projects or mobile apps, and if you have any ideas, we can work on a new project as well. Same with posters, abstracts, and manuscripts. If you have any new research questions, please let us know. Any new ideas. Thank you so much, Dr. Anna, and your team for this great presentation and sharing for your update. So I think the next step is to work with like finding a way to upload it to the Google Play Store.
Yes, yes, that would be the next step, of course.
Excellent. Let me know
Thank
if I can be of any help, but great job.
Thank you so much, Dr. Nader, of course. Thank you.
Yeah. And if for those other fellows who did not participate or did not have our research project, what I suggest is to work. I'm not sure if you started working, Hammad and your team, on the Arabic version or Spanish version. So these are other ways to get involved into making some other version of the same app. I think the skeleton will be the same, but the content will be in different language. That might be also get you to reach more users in other countries or in other languages. So that might be another step for other fellows who are interested in pursuing some projects. Any other addition, any other comments, any questions? Go ahead, Dr. Scanner.
Hello, Dr. Nadir. I hope you're doing good. I had a few questions regarding the ERAS application. So is it okay I can share the ERAS application here and ask you a few questions? Because most of us have a lot of questions regarding what to fill in which column, and it would be great if you can just look at it and tell us a little bit about it.
If you look at the previous applications or ERAS documents from some fellows who share their ERAS application when they match to programs?
Yeah, I know. Actually, there are like few categories here, like primary focus, key characteristics. Can I just show you and you can have an idea? Like,
yes, I don't want you to share personal information.
Yeah, just the general thing.
Whatever stuff, yeah, you want to.
Yeah. So, are you able to see it?
Yes.
So here, they have given the application this way this time. So like I have a question, like in experience type for the telegeriatric research fellowship. So here we will put the experience as research, right?
Correct.
And if we have the position title as observership, so what do you think we should put? Education, training, or work? Because the others one, I don't think they fit into the category. Research is, yeah, the research is for like our telegeriatric research fellowship, we will put it as research. But I'm asking like for our other experiences like observership or hands-on experience. So for observership, do you think we should put experience as category as work, or do we should put it as
education training? I think
education and training.
Yes.
Okay. And my next question is, for example, here in the primary focus, they have mentioned us things like basic science, clinical transitional science, community involvement, healthcare administration, medical education. So if it is our telegeriatric research fellowship, so do we put the clinical transitional science, or what should we put? Medical education?
Medical education is the closest I see from the
medical education. Okay, and if this is suppose observership, so should we again put medical education, or
observership? I think for clinical and translation science, so it's going to be clinical.
Clinical science, okay. And then coming back to this point, which is key characteristics. So for telegeriatric research fellowship, I think teamwork and leadership should be the good option to choose. What do you say?
What
and if
scroll up?
Yeah, so other ones are communication, critical thinking, cultural humility, empathy, compassion, ethical responsibility, innovation, reliability.
Yeah, it depends. I think if you can select more than one, that would be correct, but team leadership is okay. Some others might apply as well. Innovation, if you are working on the app like
innovation.
Hammad, and communication might be, so critical thinking, all this can apply to the fellowship. So you are involved in a project and you apply to all these qualities.
Okay. Is it okay to choose anything like for observerships? I don't find anything like to fit, like if we are doing some, if we have done some observership, like what can we choose, like communication or like, what do you think for observerships or any rotations?
Critical thinking is good, observership. So most likely they will ask you what do you think is this case and how you can plan to manage this case. So it's going to be communication as well as critical thinking, problem solving kind of approach. So either one would be good. I think they're linking the way, but I think you can just see whichever you like best, describing your improvement, for example.
Right. Thank you for this, Dr. Nadir, but I have one more question, which is, for example, in case of, if we have done observership with a preceptor and the preceptor during the observership asked us to do any physical examination, like just auscultate on the patient or do some particular physical examination. So is it advisable to write it in the description that we did this physical examination under supervision, since in observerships we're not allowed to do any kind of examination, we're just allowed to observe.
I don't think you need to, I don't think you need to mention it because legally you are not supposed to. Maybe the observer or the preceptor is just kind enough, but it can get you and then in trouble. But in general, legally, if it's not permissible, then don't mention it. And if you go back to the question, the first one, when you're selecting things, if you select one and you think there is another criteria that from the drop-down list, there is a box down, you can add all these applied things from the list, from the drop-down. In your text, you can elaborate more. So if you select team, member, and work, if you want to add more communication, you can, in the text, you can say, I improved my communication skills. I whatever innovation is applying this new concept or working on new apps or developing something, whatever critical thinking, we are solving some common issues that is some of the other something like that. So you can select some of these as well in the context.
Okay. And do you suggest, like when we write about our rotation description, like exactly what we did during the rotation, our roles and responsibilities, do you think we should write particularly like we saw cases like, for example, stroke patient or a CHF case or a COPD case, or it is not like, should we mention the name of the cases just to show that like what kind of like examples, should we give examples of cases or just generally write that we got to see cases and not name them particularly?
No, I think maybe might help, specifically if you are targeting certain, like if you are going to apply to neurology. So see cases with dementia, stroke, whatever, Parkinson, might tell them that you already saw some of these patients and you are interested in this and actually you did some. In general medicine, you can mention any type of cases. So I feel don't bother like listing a lot. And this is not the place. This is just to give them flavor or idea about the. So if you want to mention a couple, 2-3 cases, that might be okay. And see the common thing in the area where you want to apply.
Okay. And one last question is, for example, this time they have not given us a separate column to put our hobbies and interests. And then we just can put our hobbies and interests in here only in the application, in the experience part only. Like they have given us an option here, the extracurricular activities, club hobbies. So do you advise us to write interests and hobbies as maybe in the interviews we might get a chance to talk about them? And is it okay to write more than one hobby in this section? What do you suggest?
Oh, sure. Yeah, if you have one hobby, it's easier. If you have more than one, again, it depends on your application. You don't want the application to look longer than photo. So you can combine if it's related hobbies. But if it's not related, you can mention different ones. So first one will be I like let's say swimming and walking or something like that. So both of them are exercise related, something like that. So you can mention both of them and I can elaborate on that. If it's different, like bird watching or something like painting, and then you can add them as separate. So the first one will be painting. I like to work with oil paint, something like that. I participated in one of the conferences or presented my work like this. If you have something, if it's a different one, you can add it as a different copy as well. And if you want to elaborate, that's fine. You can add as I'm not sure if it's gonna be like the language as well. So if you speak Arabic, English, Spanish, Hindi, or some, you can add the extra additional languages there, and you can elaborate on the level. So, and again, there is no right or wrong way of doing things. So it cannot come as a list. So it's going to be separate. So it's just a matter of refining your application to the eye for the one who is looking at that. If you have many things, you can put them together. They are related, easier for them to look at one place rather than one, and then go to skip paragraph and then two, and then two and paragraph. So it's going to be what's called time consuming for the person to look at your first copy, second copy, next page, third copy, something like that. But if they are related, maybe you can just put them together.
Okay, thank you so much. I mean, it was really helpful, and thank you for answering all my questions. I really appreciate it. Thank you.
So anytime, and I wish you all the best.
Thank you so much. Please keep us in our prayers. All of us need your prayers also. Thank you.
Thank you so much. Good luck. Any other questions? Any other comments? Oh, Dr. Mohamed, please go ahead.
Hi, everyone. How are you? Can you hear me?
Yes.
Yes,
okay.
We can hear you.
Okay,
Hello.
That's good. First and foremost, I hope everyone is doing okay. So I do have two updates. One is for the poster presentation for the challenge of older patients with COVID-19. I think we have shared with you the poster, and it's almost like 95% ready. And the second one is, if I can share my screen. I was about to address the previous callers. This is what, can you see my screen?
Yeah.
So this was one of my friends messaged to me from LinkedIn. I was just trying to answer the previous caller questions. So this is what you should include in the ERAS. For the basic sciences, it says scientific disciplines such as biology, chemistry, physics, anything to be associated with basic science. For clinical or transitional science, so if you are involved in diagnostic, for example, hands-on clinical experience, observership, or any form of hospital rotation, it should be as a clinical or transitional science. The third one is the community involvement and outreach. So if you have done, volunteering such as closing, food drivers, fundraising, public education should be included in this sector. The first one is customer service. For example, if you work as a receptionist or medical assistant in a hospital where you don't have direct access to a patient, you could include it here. The next one is healthcare administration, such as most job titles associated with administration rather than direct patient contact. And the next one is improving access to healthcare. So this is like if you do outreach programs out of your city or organization for vaccine or providing healthcare to limited access, you should include it here. And after that is medical education. So if you are a tutor or researcher or peer reviewer or someone trying to do something associated with academic institution, you should include it here. And for music, athletics, this is, I think, straightforward. You don't need to go into detail. Promoting wellness is also important. For example, if you work in outreach program for a COVID in a city 400 or 500 miles out of the main city, that is considered to be promoting wellness, or coaching or mentoring to others, which eventually have the objective of giving healthcare to the underserved, will be subcategorically put on promoting wellness. In public health is a bit different. So if you do have, for example, masters in biostatistics, epidemiology, or global health, or if you're a nutritionist, or if you work in a malnutrition center, you can include it in public health. Quality improvement is more of like a public health sector. So patient safety, adverse drug reaction institutions, implementation a plan to reduce secondary infection disease on patients will be included in quality improvement. Social justice and advocacy is more of like associate with people who, on the behalf of other people, promote for the underserved society. So diversity, equity. If you work in a institution or community where 5% or 10% of the people are, let's say, underserved race, or Black, African American, or Asian, you will include it here. The last one is technology. So if you, let's say, have added experience of IT masters or coding or genetic engineering, biochemistry will be included here. So depending on this, you can choose what kind of experience you had, and you can subcategorically enter the next box, which the previous person who was questioning about the ERAS application, you can subcategorically choose from your boxes. Most of us do observership, hands-on clinical experience, research, volunteering, and if you have added degrees such as Masters of Public Health or Statistics. So most of us fall in basic science, clinical or transition science, community involvement. For those of you who have worked in medical assistant, customer service. For those of you who worked as a volunteering, plus or minus giving services to the underserved, will fall in here. Research will fall in here. This is a personal hobby. This is outreach program. This is added degree in your career, such as public health, statistics, or nutrition. This is more of like quality control. If you have a public health master's, or if you have 2 years of degree in public health, it will be included here. If you are more interested into lawmaking, it will be included here. And if you have added skill in your CV, which has nothing to do with medicine, will fall in here. So subcategorically, you can put your CV depending on this. Thank you.
Thank you so much for sharing, and for those who came and joined the fellowship. So we will be contacting you as far as teamwork and getting you involved in some of the projects. So someone will be in touch with you soon. Dr. Maya, go ahead. Thank you so much, Dr. Mohamed, for this. And if you can share this, I sent you a text. So that would be great. Dr. Maya, go ahead.
Okay, I will
Hello,
share.
Dr. Nadir. Hello,
Hello,
Dr. Nadir. Hope you are doing well. Hello, everyone. First of all, many, many congratulations to our team for this creation of adult vaccination app. And thank you so much, Dr. Amal. Without your help, it's not possible for us to make in such short period of time. And Dr. Nadir, I have a question. In ERAS, where should we mention for this app, about this app, like in description, where we are giving a description about we are doing fellowship and like activities? Where should we mention about this app?
You can add it to the fellowship program, or you can add it as in other experience that you have as development of new mobile app as an innovation way of volunteering with or reaching out to patients and follows.
So, in experience, where we are mentioning our experience in experience portion.
You can add it as experience because it's a new experience for you guys, and you can add it when you elaborate on what did you learn from this fellowship. So you will add the fellowship as a research. When you are adding the description, you can mention that you was involved in app development as well as in the research of the experience part. You can also mention it, and you can elaborate on that you were involved in this and what type of task or what things you did or you learned or your role basically.
Okay, Dr. Nader. Thank you so much. Sounds good. Thank you so much.
Sure. Go ahead, Dr. Sonia, about it.
Hello, Dr. Nader. How are you?
Good, thanks. How are you?
Good. So I'm just asking about the access for the ground round for Sparrow Hospital. It's said that it starts on September 10th. How to access that? We're not able to see any link or anything to access the ground round.
It's gonna be on the app itself. If we go scroll down, I think. So if you look the app, if you scroll down, you can just see Friday, the neurology ground round, and above that will be Sparrow ground round. I think this is the ID and the passport. If not, I'm gonna update it to show the new one. The other way to get it, I think this is the MSU neurology. And I'm gonna add it somewhere here, more information about the intermittent ground round. It's gonna be in the app. So
Okay, thank you, Doctor.
you're welcome. If there is no more questions or comments.
Dr. Nader, hi.
Yes, go ahead. Hi, how are you?
Thank you. I'm fine. Thank you very much for updating my LOR. Appreciate it.
No problem.
I have a question about ERAS, the geographic preference. Should I, whatever, if I choose like East, North, Central USA, what should I mention? Like my bonding to this area, or if I visited these states and I like the weather or whatever. I don't know exactly what should I mention in the description of preference.
So what happens is some people have their kids, so they can look at school area and think this is a good fit for their kids. Some people like the weather, so you can mention that I like this because it's compared to mine, whatever. And then and anything that you think is attracting you to the area. In my case, I moved to Michigan because it's closer to my in-laws in Canada. So you can just mention anything related to you personally.
Okay. Thank you. Appreciate it.
Dr. Nader, I have a like regarding our BP app or the vaccination app, like can we put it in, there's a column in ERAS application saying like accomplishments. Could we put it under the accomplishments, like our BP app or vaccination app? Okay.
Oh, sure, yeah, sure. And one thing you can do, if it's published on Google Play Store, you can add the link there as well. So they can look at that, and if they want to look it up, they can.
Yeah, right. Okay. Yeah, that would be great. Thank you.
Excellent. Yeah, good questions. Any other questions or comments?
Hello, Dr. Nader.
Hello, go ahead.
How are you?
Great, thanks.
Dr. Nader, I have a quick question. So For our telegeriatric research fellowship, we'll put the position for ourselves as fellow, right?
Correct.
And where can we mention your name?
So I think you can mention it in the same text where you have a big box. You can add whatever things that you learned, skills or knowledge or anything. And at the end, you can say, my mentor was Dr. Abdurrahman, who was a pediatrician, if you want to elaborate. But
Thank you so much. Thank you.
you're welcome. No problem. Thanks. I'd like to thank all the presenters from today, Dr. Rufida for moderating this Zoom meeting and all contributions. Thank you all attendees from today, and thanks to those who will come and video the recording later. I wish you all the best and have a wonderful day or night. See you next week. Assalamu alaikum.
Thank you, Dr. Nader.
Thank you. Appreciate
Thank you
it.
so much, Dr. Nader. Thank you.
Thank you, Dr. Nader.
Thank you.
Thank you.
Have a great day.
Thank you, Dr. Nader. Assalamu alaikum.
Thank you, Dr. Nader.
Thank you so much.
Thank you, Dr. Nader.
Assalamu alaikum. Thanks.
Thank you, Dr. Nader.
Thank you. Bye-bye.
Thank you. Bye.